Thank you so much for having me. Honored to be here. And a common procedure, actually, sorry. Anyways, I don't have any disclosures. I'm the founder of a company called Solvay, and we're making a non-thermal, non-tumescent for superficial venous ablation. I have a presentation on it later, but it's not FDA approved, so we're not going to talk about it. So just to start, super simple, right? Leaky valves are the underlying problem. You've got superficial venous insufficiency. It's by far the most common vascular condition that affects probably many of our patients, and often if we're focused on arterial disease, we may not pay attention to it, but it can be a cause of morbidity and mortality, cause wounds, et cetera, and definitely worth paying attention and can improve a patient's quality of life. I worked with a wound care specialist who unfortunately got leukemia, and so she had to retire at an early age, and I inherited a lot of her wound care patients, so I started to do wound care for some of these patients, and now I actually have a wound care component to my practice. And this is actually a 93-year-old nurse who used to work at Harvard UCLA in the cardiology department, and obviously hasn't worked for quite some time, but had 3 subsequent DVTs over the course of 20 years and wasn't diagnosed with a May nerve that she had, so we recanalized her left iliac vein, we treated her superficial venous insufficiency, and we performed wound care, and we got this 100-centimeter ulcer to heal in 6 weeks, 6 to 8 weeks, when she'd had it for 3 years. This is the basic SEEP classification. I see patients all along the spectrum, but definitely I think when we think of venous disease as just cosmetic, we're definitely doing patients a disservice. It can be a cause of ulcerations, pain, et cetera. Definitely worth paying attention to. Basic anatomy, when I talk to patients, I tell them their deep system is like the freeway. They're the main veins, often functional. In the case of superficial venous insufficiency, and the superficial veins are like surface streets, and the perforators are the freeway on-ramps that connect the superficial and deep system. And I think that obviously the people in this room are expert vascular physicians and they know the anatomy well, but a lot of superficial venous disease is treated by non-vascular physicians, internists, primary care specialists, dermatologists, and people have mixed feelings about that. But the reality is that those people are performing these procedures. And I think that often what will happen is patients will go to a quote-unquote vein clinic, and really they'll only address their truncal veins, the GSV and the SSV. They won't look at the perforators, they won't look at the truncal variants, et cetera. And the patient gets partial treatment, whether it's pain that doesn't resolve or an ulcer that doesn't heal. So it's important to pay attention to those accessories. The challenges, obviously we've come strides and long ways from traditional surgery, and traditional surgery works, of course, well as well. But the reality is that we haven't had a whole lot of innovation in the space in the last decade. And there are still some challenges that we face with the treatment of superficial venous insufficiency. While the outcomes are effective, nerve injury, irritation, blood clots, et cetera. And I think that we can make interval improvements in the treatment of superficial venous insufficiency to improve outcomes, but also improve the ease with which the procedure can be done so that more operators can have access to the technology. Thermal ablation is definitely the quote-unquote gold standard. It works. That vein will be gone if you do it appropriately. And the technique is relatively straightforward, right? It's a static catheter. You just have to do the tumescent, which is irritating if you're not good at ultrasound, but veins are generally irritating if you're not good at ultrasound, so you have to definitely get your ultrasound skills up. Venous seal is a cyanoacrylate, a glue, which will glue that vein shut, so you avoid the need for thermal and tumescence, and you avoid the risk of nerve injury. But, all these tools are great, and some people like one, some people don't like the other, but some of the issues can be a foreign body infection or hypersensitivity reaction. And then Varithena is a polydocanol microfoam that's deprived of nitrogen, and FDA approved, clinically available, reimbursed, has a code. It's great because you have unlimited degrees of freedom. You can really treat any venous anatomy with it, but it does have its limitations in the sense that you do have to be good with ultrasound, you have to do control where the foam goes, and you can have issues with ablating large veins. There can be trapped blood, et cetera, and hyperpigmentation and pain. So my algorithm, I've used a lot of glue and liquid embolics and physician compounded foam in my personal practice. So I'm comfortable with unlimited degrees of freedom because I can do what I want with it. So I tend to use a lot of microfoam. But typically if I have a large vein above the knee, I'll use RF because it just works really well. And you don't have to worry about trapped blood, hyperpigmentation. If that GSV does come out of the saphenous plane, it goes really close to the surface of the skin. You want to be careful with RF because it can cause a skin injury. But those veins are generally tough to treat. If you use glue, it'll leave a cord. If you use polydocanol, it'll leave hyperpigmentation. So you can either do a stab phlebectomy, or sometimes I use Clarivane. I can also use RF, but I make sure that there's a centimeter of tumescent between the skin and the RF catheter. And I used to do a lot of like RF for kidney tumors and chest wall tumors with cryo. So I'm used to hydrodissection, but just make sure that you're comfortable, doing that hydrodissection and making sure that the catheter is far from the skin. Below the knee, I typically like non-thermal non-tumescence. I like Varithena. One of the misconceptions that people have with Varithena is that you actually want to worry about DVT at the saphenofemoral junction. You probably want to worry about it more below the knee. One, because that's where the perforators are, and everyone's just going to be looking at the junction, but that perforator is what's going to get you. And two, the popliteal vein is smaller than the femoral vein, so you're more likely to get a DVT there, so you want to worry about it lower down. If a patient can't tolerate RF or the tumescent, non-thermal non-tumescents are a great choice. If it's a tortuous vein, I know, you're all wire and catheter maestros, and you can get that wire to go up that crazy tortuous vein, but I don't torture myself, I just use microfoam. And another area I think that's worth paying attention to is those ulcer patients. You definitely want to treat the perforators, probably with RF or laser with a stylet. But if you really want to get that bed of venous hypertension under the venous ulcer, I think microfoam is amazing, whether it's physician compounded or Varithena. The thing to keep in mind is that the Varithena bubbles are smaller and they have a larger dwell time than physician compounded foam, so it's less forgiving. So if you're not really comfortable with microfoam, you might want to use physician compounded foam. And remember, with foam, less is more, because if you use more, you're going to get more leakage into the deep system. And you can always bring them back for another injection. Just want to avoid a DVT. And so the advantages, kind of the opposite slide, RF, faster learning curve. If you're new to veins, just start with RF, learn the technique, the anatomy, the tumescent, et cetera. Treats all vein sizes. Venous, you don't need compression, and obviously there's no tumescent. And with the Varithena, same thing, no tumescent. And it's good for versatile anatomies. And if you stay for the presentation on my startup, I'll talk about what I hope is the next orbit for superficial venous treatment. Thanks, guys.